An overview of Delta variant of COVID-19. COVID-19 is caused by infection with the severe acute respiratory syndrome, shortly known as SARS-CoV-2 virus strain. Now virus spreads all over the world while reporting 10,000 deaths per day. There are two types of this virus identified by the researchers. They are type L and type S. Type S is less aggressive and it is the older version of COVID-19 virus which was found from Wuhan, China. 30% from total infected patients. Type L is very aggressive and it is the newest variant of coronavirus. It is 70% from total infected patients. There are four main types of proteins and genomic ssRNA in the nucleocapsid. Spike glycoprotein, known as S, membrane protein known as M, small envelope membrane protein known as E, and nucleoprotein known as N. The Delta variant, also known as B.1.617.2, can spread more easily. The strain has mutations on the spike protein that make it easier for it to infect human cells. That means people may be more contagious if they contact with the virus and more easily spread it to others. It is now the dominant strain in the world. Effectiveness of vaccination against Delta variant. Full vaccination with any of the anti-COVID-19 vaccines that have been granted WHO emergency use listing provides substantial protection against the Delta variant, especially severe disease, hospitalization, or death, as long as all the required doses have been taken. To maximize protection from the Delta variant and prevent possibly spreading it to others, wear a mask indoors in public if you are in an area of substantial or high transmission. Along with vaccination, WHO recommends continuing to avoid crowds and wash hands regularly with soap and water. Identifying different methods of ventilator settings. That is our today's topic.
But, before going to settings of the ventilator, we need to identify what is a ventilator and the process of ventilation. Ventilation is the process, exchange of air between the lungs and the atmosphere, so that oxygen can be exchanged for carbon dioxide in the alveoli. To deliver ventilation to a patient who is physically unable to breathe, or present with breathing insufficiency, ventilator is needed. A ventilator is a machine that provides mechanical ventilation by moving breathable air in and out of the lungs. In these pandemic days, ventilators being the most useful medical equipment for the patients present with COVID pneumonia. Ventilator settings. To give a brief definition, ventilator settings are the controls on a mechanical ventilator that can be set or adjusted in order to determine the amount of support for breathing that is delivered to the patient. Support can be provided in the form of ventilation and oxygenation. You must develop an understanding of how each setting can be adjusted in order to provide more or less of each type of support for the patient. The good news is, that is exactly what we're going to cover in this video. First, we want to identify the unit of the patient. Nasogastric tube goes through the patient's nose to the stomach. This is used to feed the patient while he or she able to start feeding by mouth. Endotracheal tube goes through the mouth to the windpipe or trachea. This makes a firm and sealed connection between the respiratory system and the ventilator. Mechanical ventilator blows air or air with oxygen through tubes into the patient's airways. Air flowing to the patient passes through a humidifier which warms and moistens the air. And finally a tube for exhaled air away. Identifying ventilator screen. The respiratory rate set by the user. This is the mandatory rate which the machine will deliver regardless of what the patient does. This is in breaths per minute. The tidal volume per breath. This is volume-controlled ventilation, so this is the volume of air the patient will get with each breath. They will get that 20 times per minute with this setup. Flow. How fast is the breath delivered by the ventilator? Waveform. This is a triangled waveform, which means that the air is delivered is not at a constant pressure throughout inspiration. Oxygen concentration is a percentage. In this example it is 45%. Trigger variables. Sometimes the patient may make some effort to breathe. This is just one of the ways another breath can be triggered. In this example, if the patient generates a flow of 2 liters per minute, then the ventilator will deliver another breath of 500 milliliters. Examples of the basic ventilator settings. Mode, tidal volume, frequency, rate, FiO2, flow rate, inspiration to expiration ratio, sensitivity, positive end expiratory pressure, alarms. In here we are able to describe the different modes of the ventilator. Ventilator mode. A ventilator mode is a way of describing how the mechanical ventilator assists a patient with inspiration. The characteristics of a particular mode control how the ventilator functions. Common modes of mechanical ventilation include assist, control, AC, synchronous intermittent mandatory ventilation, SIMV, pressure support ventilation, PSV, continuous positive airway pressure, CPAP, volume support, VS, control mode ventilation, CMV, airway pressure release ventilation, APRV, mandatory minute ventilation, MMV, inverse ratio ventilation, IRV, high frequency oscillatory ventilation, HFOV. Now we are going to describe one by one. Assist control mode. Assist control. or AC, is a term used to describe the number of breaths a patient is receiving from the breathing machine, ventilator. AC refers to a specific method for giving the patient mechanical breaths. An AC of 14 means that the patient's breathing is fully supported. Synchronized intermittent mandatory ventilation, SIMV, is a type of volume control mode of ventilation. With this mode, the ventilator will deliver a mandatory, set, number of breaths with a set volume while at the same time allowing spontaneous breaths. Pressure support ventilation, also known as pressure support, is a spontaneous mode of ventilation. The patient initiates every breath and the ventilator delivers support with the preset pressure value. With support from the ventilator, the patient also regulates his own respiratory rate and tidal volume. Continuous positive airway pressure, CPAP, is one of two cardinal modes of non-invasive ventilation. Bi-level positive airway pressure, or BPAP, is the other. As the name suggests, CPAP provides continuous pressure throughout the respiratory cycle. When a patient on CPAP breathes in, the ventilator machine will provide one constant pressure during the inspiration. When the patient then breathes out, the ventilator will continue that inward pressure during the entire expiration. CPAP is commonly used for patients with the following respiratory disorders: acute pulmonary edema, obstructive sleep apnea, obesity hypoventilation syndrome, Pickwickian syndrome. Volume support ventilation, VS. In volume support ventilation, the patient triggers every breath, controlling his own respiratory frequency and inspiratory time. The pressure support is automatically adjusted up or down according to the patient's lung compliance or the resistance to deliver tidal volume. This volume support mode, considered as a self-weaning mode, cannot be used patients who lack spontaneous breathing effort. Controlled mode ventilation or continuous mandatory ventilation, CMV, is a mode of mechanical ventilation in which breaths are delivered based on set variables. Still used in the operating room. In previous nomenclature, CMV referred to controlled mechanical ventilation, control mode ventilation. A mode of ventilation characterized by a ventilator that makes no effort to sense patient breathing effort. Airway pressure release ventilation, APRV, is a pressure-controlled mode of ventilation that delivers an almost continuous positive pressure with intermittent, time-cycled, short releases at a lower pressure. Spontaneous ventilation is encouraged, and the relatively increased mean airway pressures allow open lung ventilation. APRV was first described in 1987 by Stock and colleagues, who demonstrated that arterial oxygenation and carbon dioxide clearance. Mandatory minute ventilation was the forerunner of more modern, automatic methods designed to change the device's performance to achieve a specific clinical goal. MMV guarantees certain minute ventilation, regardless of whether the patient is trying to breathe. Inverse ratio ventilation IRV. is an alternative strategy for mechanical ventilation that reverses the classical inspiratory-expiratory scheme. This is achieved by modifying the inspiratory to expiratory ratio, typically with the intention to increase oxygenation by increasing the mean airway pressure, MAP. High-frequency oscillatory ventilation, HFOV, is a rescue maneuver for failed conventional mechanical ventilation. Appendicitis. What is appendix or vermiform appendix? This 3½ inch long tube or a pouch of tissue like a worm extends from your large intestine on the lower right side of your body. What is appendicitis? Appendicitis is an inflammation of the appendix. It's a medical emergency that almost always requires surgery as soon as possible to remove the appendix. Luckily, you can live just fine without it. Appendicitis happens when the appendix gets blocked. Often by poop, a foreign body, something inside you that isn't supposed to be there. Or cancer. Blockage may also result from infection, since the appendix can swell in response to any infection in the body. What are the signs and symptoms of appendicitis? The classic symptoms of appendicitis include pain in the client's lower right belly, McBurney point, or pain near the navel that moves lower. This is usually the first sign. Loss of appetite, nausea and vomiting soon after belly pain begins. Swollen belly, fever of 99 to 102 degrees. Can't pass gas. Other less common symptoms of appendicitis include dull or sharp pain anywhere in the upper or lower belly, back, or rear end, painful or difficult peeing, vomiting before belly pain starts, severe cramps, constipation or diarrhea with gas. If the client presents any of these symptoms, give necessary advices to see a doctor right away and explain about the importance of timely diagnosis and treatments. Don't eat, drink, or use any pain remedies, antacids, laxatives, or heating pads. What is the treatment for appendicitis? Appendicitis is almost always treated as an emergency. Surgery to remove the appendix, which is called an appendectomy or appendicectomy, is the standard treatment for almost all cases of appendicitis. Generally, if the doctor suspects that the patient has appendicitis, he will take measures to quickly remove it to avoid a rupture. If the client has an abscess, he or she may get 2 procedures, one to drain the abscess of pus and fluid, and a later one to take out the appendix. But some research shows that treating acute appendicitis with antibiotics may help the patients to avoid surgery. Doctor prescribe opioids, non-steroidal anti-inflammatory drugs, or acetaminophen to relieve the pain. What are the possible complications of appendicitis? Complications of appendicitis may include wound infection, dehiscence, bowel obstruction, abdominal or pelvic abscess, peritonitis, rarely, death. Stump appendicitis also occurs rarely. However, at least 36 reported cases of appendicitis in the surgical stump after previous appendectomy exist. Nursing management. Primary preoperative nursing diagnosis. Acute pain related to inflammation. Primary postoperative nursing diagnosis. Risk for infection related to the surgical incision. Other diagnoses that may occur in nursing care plans for appendicitis. Imbalanced nutrition. Less than body requirements related to nil per oral status. Impaired skin integrity related to the surgical incision. Ineffective gastrointestinal tissue perfusion. Risk for deficient fluid volume. Risk for injury. Nursing interventions. Preoperative nursing interventions. Maintain nil per oral status. Administer fluids intravenously to prevent dehydration. Monitor for changes in level of pain. Monitor for signs of ruptured appendix and peritonitis. Position right side lying or low to semi-fowler position to promote comfort. Monitor bowel sounds. Apply ice packs to abdomen every hour for 20 to 30 minutes as prescribed. Administer antibiotics as prescribed. Avoid the application of heat in the abdomen. Avoid laxatives or enema. Postoperative interventions include: monitor temperature for signs of infection. Assess incision for signs of infection such as redness, swelling and pain. Maintain nil per oral status until bowel function has returned. Advance diet gradually or as tolerated or as prescribed when bowel sound return. If ruptured of appendix occurred, expect a drain to be inserted, or the incision may be left to heal inside out. Expect that drainage may be profuse for the first 2 hours. ECMO. Extracorporeal membrane oxygenation. Heart-lung machine. In extracorporeal membrane oxygenation, ECMO, blood is pumped outside of your body to a heart-lung machine that removes carbon dioxide and sends oxygen-filled blood back to tissues in the body. Blood flows from the right side of the heart to the membrane oxygenator in the heart-lung machine, and then is rewarmed and sent back to the body. Indications for using ECMO. Used in critical care situations. When your heart and lungs need help so that you can heal. It may be used in care for COVID-19, ARDS and other infections. This does not treat or cure a disease, but can help you when your body temporarily can't provide your tissues with enough oxygen. Before watching, subscribe now to stay with us, and stay safe. is a graph of voltage versus time of the electrical activity of the heart using electrodes placed on the skin. Do you have a trouble in reading ECG? This is the simplest way. Let me show you. What is normal adult heart rate? Normal heart rate 60 to 100 beats per minute. Tachycardia, heart rate greater than 100 beats per minute. Bradycardia, heart rate less than 60 beats per minute. Calculate heart rate using ECG. If a patient has a regular heart rhythm, their heart rate can be calculated using the following method. Count the number of large squares present within 1 RR interval. Divide 300 by this number to calculate heart rate. As an example, if the number of large squares is 4, 300 should be divided by 4. It equals 75. Heart rate of that patient is 75 beats per minute. Patient's heart rhythm is irregular, the first method of heart rate calculation doesn't work. As the RR interval differs significantly throughout the ECG. As a result, you need to apply a different method. Count the number of QRS complexes on the rhythm strip. Each rhythm strip is typically 10 seconds long. Multiply the number of QRS complexes by 6, giving you the average number of complexes in 1 minute. As an example, the number of QRS complexes in an irregular ECG for 10 seconds equals 10. 10 multiplied by 6 equals 60. The patient's irregular heart rate is 60 beats per minute. First-degree heart block, AV block. First-degree heart block involves a fixed prolonged PR interval, greater than 200 milliseconds. This is a condition in which the wiring of the heart is slow to send electrical signals, but all of the signals are able to pass successfully. There is no electrical block but rather a slowing or delay of the signal. It usually does not cause problems. Second-degree AV block, type 1, is also known as Mobitz type 1 AV block or Wencker-Bach phenomenon. This is specifically characterized by an increasing delay of AV nodal conduction until AP wave fails to conduct through the AV node. This is seen as progressive PR interval prolongation with each beat until AP wave is not conducted. There is an irregular RR interval present. Second-degree heart block, type 2. Second-degree AV block, type 2, is also known as Mobitz type 2 AV block. Typical ECG findings in Mobitz type 2 AV block include a consistent PR interval duration with intermittently dropped QRS complexes due to a failure of conduction. The intermittent dropping of the QRS complexes typically follows a repeating cycle of every third, 3 to 1 block, or fourth, 4 to 1 block, P wave. Third-degree heart block or complete heart block. Third-degree or complete heart block, CHB, is an abnormal heart rhythm resulting from a defect in the cardiac conduction system in which there is no conduction through the atrioventricular node, leading to complete dissociation of the atria and ventricles. The ventricular escape mechanism can occur anywhere from the atrioventricular node to the bundle branch Purkinje system. Third-degree AV block is electrocardiographically characterized by regular PP interval, regular RR interval, more P waves are present than QRS complexes, lack of an apparent relationship between the P waves and QRS complexes. Delta wave. Delta wave is a slurred upstroke in the QRS complex often associated with a short PR interval. It is most commonly associated with pre-excitation syndromes such as Wolff-Parkinson-White syndrome, WPW. the characteristic ECG findings in the Wolff-Parkinson-White syndrome are short PR interval, less than 120 milliseconds. ST elevation. The ST segment represents the interval between ventricular depolarization and repolarization. ST elevation is most commonly caused by acute full-thickness myocardial infarction. ST depression. ST depression occurs when the J-point is displaced below baseline. Just like ST elevation, not all ST depression represents myocardial ischemia or an emergent condition. There are multiple conditions associated with ST depression. The main cause is myocardial ischemia. Other possible causes are hyperkalemia and medications such as digitalis. T waves. T waves are considered tall if they are greater than 5 mm in the limb leads and greater than 10 mm in the chest leads, the same criteria as small QRS complexes. Tall T waves can be associated with hyperkalemia, tall tented T waves, hyperacute ST elevated myocardial infarction. Biphasic T waves. Biphasic T waves have two peaks and can be indicative of ischemia and hyperkalemia. Flattened T waves. Flattened T waves are a non-specific sign that may represent ischemia or electrolyte imbalance. For watching, subscribe now to stay with us, and stay safe. Is the medical term for chest pain or discomfort due to coronary heart disease. Pathophysiology. Angina pectoris is the result of myocardial ischemia caused by an imbalance between myocardial blood supply and oxygen demand. Angina is a common presenting symptom, typically chest pain, among patients with coronary artery disease. Causes for angina pectoris: hardening of arteries, atherosclerosis, a blood clot, plaque in an artery that can rupture, unstable plaque, poor blood flow through a narrowed heart valve, lessened pumping of heart muscle, coronary artery spasm. Of angina pectoris. Microvascular angina. This used to be called Syndrome X. It causes chest pain with no coronary artery blockage. The pain is caused by from poor function of tiny blood vessels that lead to the heart, arms, and legs. It is more common in women. Variant angina pectoris. This is also called Prinzmetal's angina. It is rare. It occurs almost only at rest, not after exercise or stress. It usually occurs between midnight and 8 a.m. It can be very painful. It is related to spasm of the artery. It is also more common in women.
Treatment for angina pectoris. There are many options for angina treatment, including lifestyle changes, medications, angioplasty and stenting, or coronary bypass surgery. The goals of treatment are to reduce the frequency and severity of symptoms and lowering the risk of a heart attack and death. However, if you have unstable angina or angina pain, that's different. What usually need immediate treatment in a hospital.
For watching, subscribe now to stay with us, and stay safe.